Thank you very much for the invitation. I work in Ahmadit in a polyclinic, and I do my best to provide our patients with help, those patients who require urgent assistance. And also my major goal is to improve the health of bones. Can you see my presentation on the screen? Yes, we can. I apologize, I'm a little bit nervous. So all the patients who need help, please, you can come to us to Ahmadit Polyclinic. Today I would like to speak about the problems with nutrition, nutritional status with DMD, and regarding the problems which we have is the loss of weight or excess weight, and later on we can talk about this. For example, there is patients with obesity or with other disorders, and the nutrients balance is disturbed. Also, very often patients, especially adults, have problems either with due to this obesity or due to certain need of assistance during lung ventilations. They lose liquids and next liquids in the body, and then the next complication which negatively affects the way the quality of life is osteoporosis and complications. What are the causes of such disorders in patients with DMD? This may be a problem with eating, for example, that the patient might need gastrostoma or zoned nutrition. Also, the lower jaw bones and contractures of lower jaw bones aggravate and complicate the intake of food. Also, the administration of glucocorticoids can cause obesity, and also the patients with Duchenne disease, when due to immobilization, they have loss of energy and there is a disbalance. A child can get the same products and food as before, but then the loss of energy is less. So this may be a cause of obesity. And another common cause is immobilization, which leads to the fact that a child is quite not active and cannot cannot just easily stand up and walk to take some food to eat. When today's trials show that the cause of obesity with Duchenne in patients with Duchenne disease might be is not determined yet. This may be due to the lowered activity, or maybe with the problems with the also there is with metabolic disorders. Also, there were several trials whether the basic energy need of children with DMD are lower or higher than in normal kids. And we can see that there are two trials who studied basic energy exchange and energy turnover. And it shows that patients, 310 patients with DMD, they have higher basic energy exchange. The patients were from 11 to 29 years old, and this basic energy exchange increases with age, while patients who already have mechanical respiration support, they have lower energy need compared to healthy people, and we calculated this need according to the Harris-Benedict formula. Based on the recommendations which I found, it is recommended to calculate the general energy need according to the formula, basic energy need multiplied by the rate of physical activity. But this is only the primary number, and then it is important to monitor the body weight and then decide whether this number is sufficient, or the number of kilocalories is sufficient, or, for example, a child has excess weight, and then you can already correct the nutritional status of a patient individually. Today, there are already the basic indicators of energy in children, or we can calculate the formula with the where there is age, weight, and gender, and also the activeness rate, because if a child is in lying position all the time, the coefficient of activity rate is 1%, is 1, and for sitting position is 2, and for walking children is 1.4. What are the needs in nutrients and microelements and vitamins? Of course, these patients with DMD, they need to have control of vitamin D in their blood. If they have an optimum content of vitamin D or insufficient, they have to take vitamin D. And if there is a vitamin D deficit or a severe deficit, there are doses which are prescribed to such patients daily for 3 months. And after that, there is they determine the level of vitamin D in blood again. If there is the optimal level up to 60, more than 60 nanogram per milliliter, it may be enough. The dosage of vitamin D up to 4,000 is international units is enough for patients with severe vitamin D deficit. If a patient is administered with glucocorticoids, he or she should also take calcium medications, 30 to 50 milligrams per day, such as the dose, or it is possible to prescribe 7 and it is very important to prescribe combined medications, calcium and vitamin D together in one. Also, regarding the anthropometrical data of DMD patients, the height of the DMD patients is lower by 1.5 to 1 cm compared to the peers. Also, it is ascertained that such patients, the deflazacort, have glucocorticoid, they cause these growth indicators lower compared to those who do not take them. And it's very difficult to measure height in teenagers who already have scoliosis and contractures. So we recommend, it is recommended to evaluate the length of the upper extremity and in order to evaluate the height of a patient. Regarding the body weight, we also have very interesting results. The first results by McDonald that show that the patients from 9 to 13 years old have obesity, while the age over 17 years old has already 65% of them have body mass deficit. Before puberty, there is an inclination to obesity, but older kids already have an inclination to body mass deficit, body weight deficit. And the trial showed that in the age category, the Wheeling trial showed that in the age category of up to 13 years old, the deficit of body mass was in 54% of boys. So in such a case, we use if the index body weight index is difficult to measure, we use other indicators. Currently, there are normative charts for body weight of patients with DMD. We are not supposed to use the national diagrams for such patients in order to interpret whether the body weight is normal or not. But the national anthropometric diagrams are very important in terms of longitudinal monitoring of patients, because they allow us to monitor and see how a child is developing, whether the weight is increasing or on the contrary, it is decreasing. So the evaluation of the body structure, body build, is a very efficient tool to measure the status of DMD patients. If you see the problems with, for example, evaluating body weight or height and skin, but now there is also other methods like MRI and DXA, and they enable us to evaluate the body build and the fat content in body. This method enables us to evaluate the level of fat in fat weight in the body, and also by separate parts of the body. And this method also enables us to evaluate non-fat mass weight. So this basically shows the scope of muscles in a patient. These studies are very promising for DMD patients. Also, this densipometry enables to evaluate the dynamics to see how the fat mass decreases or increases, and what is the dynamics of muscle mass or fat mass decrease. Obesity arises because there is lower in mobility, and this means that the decrease of the
it has a negative impact on the muscle tissue because there is the contraction of the muscles. Also, obesity has a negative impact on the breathing function. As usual, patients have higher frequency of breathing. Also, obesity has a negative impact on psychological development, complicates the development in general, especially the second and the third type of obesity. And also, I would like to say that corticoids increase the volume of subcutaneous tissue, and corticoids have a positive impact on the muscular tissue for the patients with Duchenne. And also, we have to balance nutrition for patients with Duchenne and decrease the percentage of the fat tissue, and that will have a positive impact on the muscular tissue. And the saying we know, eat less, move more, will decrease obesity. With Duchenne disease, it doesn't work. We have to keep that in mind, because the negative energy balance, I mean, when the child starts limiting himself or herself in food, it leads to the decrease of the muscular volume as a result of the nutrient deficiency. And of course, the child will have no possibility to recover that muscular tissue. And the influence of different diets to muscular and fat mass showed that healthy people who limit themselves in food lose 70% of subcutaneous tissue, but 30% loss of the muscular tissue, which does not recover later. That's why here we have to balance nutrition for these patients to prevent the obesity and this way not to have an influence on the muscular volume. What are the reasons of the decrease of the muscular volume for children of older age? First of all, reduction of mobility, limitation of self-nutrition. So if the child is on the wheelchair, the child may have problems related to getting some food. In terms of the disease progression, and there is the decrease of the movement of the neck and head position, and also the wrong help from the caregivers and the decrease of the cognitive functions, the problem with opening mouth or chewing the food, and the episodes of choking since it causes fear for the patient, and the patient may have fear during the next food intake to eat hard food. And the patients start eating soft food, but the change of the texture of the food which is grated decreases the nutrients because the grated food has fewer nutrients and fibers and so on. So the color rash of the grated food in contrast to the food which was not cut on the grater is different. So this triggers lead to the development of the deficiency of the body mass. And in this case, we have a different tool. We can put gastrostome, which will enable the patient to receive necessary calories and avoid the deficiency of the body mass. But it's important to put gastrostome before respiratory dysfunction and disruptions appear, since it may lead to the problems with anesthesia during the gastrostome placement. It's recommended to put gastrostome at the age of 19 or 22, from 19 to 22. And the next trigger, depending on the nutrition, is the quality of the bone tissue. Patients with Duchenne have osteoporosis as a rule, and the development of it is influenced by progress in muscular weakness, since there is the correlation with the muscle and the bone. And also the next trigger is immobilization, which triggers the cascade of the resorption of the bone tissue, and the patient loses the bone mass very quickly. And it's possible to lose up to 30% of the bone mass during immobilization. Also, inflammatory cytokines, which are usual with Duchenne dystrophy, will lead to increased resorption of bone tissue. Apart from that, corticoids, glucocorticoids, have the impact on the structure of the bone. On the one hand, it decreases the number of osteoblasts and the formation, and on the other hand, it increases the resorption. And the third effect is the decrease of absorption of calcium in the intestine and increased metabolism of vitamin D. Apart from that, the patients with Duchenne have the deficiency of vitamin D, since they have the lower insulation. And all these triggers lead to the fact that the patient has low bone density, and it leads to osteoporosis. Nataliya, you have a few more minutes, and then please you'll have to finish. And also you can see that the frequency of bone fractures is very high for patients with Duchenne, but I also want to say that vertical fractures are very usual for such patients. They may be the first ones, and it may signal osteoporosis. That's why the patients who have Duchenne, it's important for them to run densitometry and genographics in the side projection. If the patient has the pain in the backache, then X-ray of the side projection should be done during the acute pain, or if we had this X-ray planned once in 2 years. We have to do it more frequently because it enables to identify the fracture. Right now, we can treat the patients with osteoporosis with Duchenne when there is at least one fracture, not necessarily vertebral. And right now we have the medications which have proven to be effective with Duchenne disease. And there are two medications, pomedrone acid, and it's decided with the patient what medication should be used. And this therapy may be up to 2 years. And then it's important to decide to stop that therapy or to continue the support and assistance therapy. Thank you.